Thank you, Josh. It's a pleasure to be here, everybody, and it's a pleasure to introduce our main speaker, Dr. Joshua Case. For background, Dr. Case went to medical school and graduated in 2010 from SUNY Downstate in Brooklyn, New York. He did his residency and completed that in 2013 at the University of Pittsburgh in Pittsburgh, Pennsylvania, obviously. And he's been a practicing card-carrying hospitalist since graduating from residency. Like many young hospitalists, he had his first leadership position only a year after residency in 2014 when he was a program director. And about a month ago, he began as the medical director for hospital medicine clinical operations at Northwell Health. And so I just wanted to say, Dr. Case, Josh, thank you so much for doing this. It is a very important topic, and I, for one, am very interested in hearing your talk.
Well, thank you so much. I'm honored to be speaking to everyone today, and I agree. I think this is critically important for us as we navigate through this pandemic. So, as mentioned, I am the medical director for hospital medicine at Northwell Health. So we are the largest provider of healthcare in the New York metro area. In my role, I assist my directors at 15 adult medical surgical sites. As you can see on this slide, which I stole from the New York Times, we unfortunately are in the middle of the reddest part of the red there on the right-hand side. And we are at the forefront of this COVID-19 pandemic. So my goals for the talk today, so it's critically important that we use the PPE that we have appropriately and wisely. We need to balance safety of ourselves and our other staff in the hospitals with appropriate clinical reasoning as to when it is and is not necessary to don the PPE resources that we have. We're going to discuss extending the life of N95 masks safely. We're going to discuss limiting our overall exposure and risk to COVID-19 while we're seeing patients, and overall ensure that we have these critical items when we need them and when our colleagues and other staff members do. So overall, kind of the basic supplies we need for PPE in order to see a COVID-19 patient. I think a lot of us are already familiar with this. So we require an N95 respirator. Hand sanitizer needs to be very handy. Either a surgical mask or a full face shield. We'll go over the difference there, at least in how we practice this at my institution shortly. So we need to have a contact precaution gown, non-sterile gloves, a shield and or goggles. So each hospitalist in our organization, we're working on ensuring they have goggles because disposable face shields are certainly in short supply and the goggles are a bit easier to clean. Some optional things that are not necessarily recommended by the CDC, but is helping to have our staff members feel a little bit safer about things. And I think that's really important, is to be as comfortable as we can in taking care of these patients. Is hospital issued scrubs, which they're able to put on when they get in the hospital and take off before they leave. So they're not feeling like they're bringing germs home to their families and loved ones, as well as a bouffant or a cap. Again, that's not recommended, not necessarily recommended, but is optional and may make people feel more comfortable. So when does a healthcare worker, whether a physician or a nurse or NP or PA, require an N95? So we are using these, or full PPE really. So close contact with a known or suspected COVID-19 patient. So there's been a lot of discussion back and forth. What does that really mean? It does not mean every patient in the hospital. We do recognize that there are some patients that could be asymptomatic carriers. They may be slightly before that symptomatic stage. Realistically, if we don full PPE, use N95s for every patient that we see in the hospital, we're going to run out. We need to be responsible. We need to use our clinical honesty in deciding when it's appropriate to do this or not. Additionally, our guidance for donning full PPE for these patients is within 6 feet for at least 10 minutes is considered a high-risk exposure. One of the things that we've been doing at our institution, and I recognize not all institutions at this point may have the resources for this, but is providing a regular procedure mask or surgical mask, whatever you may want to call it, for all of our healthcare workers to wear whenever they're within the walls of the hospital, and our patients as well. With both people having a mask on, we do believe that your risk of contracting COVID-19 is markedly lower than it would be with no protection at all, while this is also helping us to reduce the amount of N95 or full PPE that we're using. So besides just the actual amount of PPE that we have, so talking about the donning and doffing of all of this, so at this point at our hospitals, we have numerous units that are entirely full of COVID patients and a number of teams that are only taking care of presumed or known positive COVID patients. So putting on and taking off all this stuff is really time consuming. It's both physically and emotionally challenging, exhausting, and stressful. So we really want to be intentional as to when we want to put ourselves through this. So as for your particular supplies at your individual institution for donning and doffing, ensure you work with your local infection prevention or infection control offices for the specific processes and the specific supplies that each of you will have at your institution. There may be differences in masks, differences in the gowns that you have. There's lots of videos as examples online. But I wouldn't want to show you all one specific video when your resources may be slightly different than what we are using at Northwell Health. So in preparation for, we're all going to have to see these patients if we're not already. A lot of the advice I've gotten from my teams is practicing and getting comfortable. It does, the process of donning and doffing this stuff does get easier as you go through it more and more. Having a buddy system has helped really with anxiety and also not making mistakes in how we're putting on or taking off all of this PPE. Having someone there to ensure you're putting it on right, some reminders if you forget something, so that you're going in there protected. Because these are long days, these are exhausting days, a lot of really sick patients, and we're humans and sometimes we'll forget things. So having someone there to ensure you're doing it properly is helpful. We emphasize don't go in there without donning your PPE. If they're crashing, I get it on first and then go in. The reason is that we cannot afford as a health system to lose our team members to being out sick with COVID. We just aren't going to have enough of us as a resource to lose you guys and risk your health for, or at least have you off the team for 7 or 14 days. So please, please put it on there before you go in the room. I make it akin to putting on your mask, like the video on the airplane when they tell you to put your mask on before helping someone else. Very much same thing here. We're also limiting the number of times we're going into the room. The goal really actually is 1 visit per day. Unless there's some other medical necessity for this. We're utilizing technology, whether it's tablet computers, to help the patient as well as their family communicate with them or with us. Also just calling the room phone as well is useful, and we even take some history from them sometimes over the phone. So let's talk a little bit now about what I think is both a bit of a controversial in some circles, but I think very necessary topic of N95, extended use and reuse. So extended use and reuse do mean 2 slightly different things. So extended use is when you're wearing the same N95 mask and you don't take that part off. You're going from patient to patient, leaving that mask on, and we do that on our rounds. You still have to perform hand hygiene and remove the other parts of your PPE that come in contact with the previous patient. So gown and gloves, etc., still need to be removed. It's just not removing and not touching the N95. So reuse is when you have removed the N95 and what a lot of us have read about, putting it in the paper bag and using it again in the future. So how long can we reuse or extended use these N95s? Really as long as it is safely possible. We'll go over what that entails in a moment. And yes, it is safe, both from recommendations from the CDC as well as various experiences throughout our healthcare system at this point. So I think a lot of the anxiety, both in the news that we read in the New York Times or other articles, is that this is different from our usual practice. I get that. We're used to having enough. That's one of the, I think, real benefits of practicing medicine in America. For better or worse, it's not where we are right now. Per 3M manufacturer recommendations, so this is even on N95 masks that label, quote, for single use. The quote is, there is no time limit to wearing a filtering face piece respirator. That's the N95. Respirators can be worn until they are dirty, damaged, or difficult to breathe through. And that's realistically what we're doing at Northwell. Is our guidance is even up to 100 hours of use, not just from the first time that you put it on, but total use. And we're continuing to use these until they're no longer usable per that description. People worried about what germs are on, what, is COVID sitting in there? And it is. So, however, per the CDC website, with 4 what seem like very good studies cited on their website, 99.8% of the respiratory pathogens remain trapped in the respirator, either after handling or simulated cough or sneezing. So I get it, that's not zero, but that's really, really good. So one of the ways that we are helping to extend the life of these masks is covering them. And so we have enough surgical masks at this point that we are place the N95 on and then cover it with a surgical mask. The other option to help prevent droplet contamination of the mask is a long clear shield, and some other institutions are utilizing that. Either one, from what I've been able to research, does seem appropriate at this time for either extended use or reuse, and we've had good success with that. So there's been a lot of stories and various ideas. So I've read about people slathering them with Purell or various things like that. That I've not really found any recommendations for, and I can't say I would recommend that. For your institution, Nebraska Medicine does have a very interesting ultraviolet decontamination protocol. It's not something that we're doing, but certainly could be looked at for your institution. It does, from their protocol that is easily accessible online, seem pretty straightforward. I'll have that link a bit later. So when do we replace that N95? So kind of discussed earlier when it was not appropriate. So that includes an aerosolizing procedure. We'll talk about what those are in a moment. So when the N95 becomes contaminated, either with blood, secretions, or other body fluids, when it is obviously damaged or difficult to breathe through. So barring any of those things happening, my teammates have been able to utilize the N95s for quite a long time. When you store them, you have to store them in a breathable container. That's been a paper bag or a breathable plastic bag. So aerosolizing procedures. So I think the biggest one that we as hospitalists do all the time is nebulizer treatments. We have stopped essentially doing nebulizer treatments. We have replaced this with metered dose inhalers with a spacer. The nebulizer it's aerosolizing. It utilizes far too much PPE. There's not great data that overall shows that a nebulizer is any better than a metered dose inhaler with a spacer at delivering respiratory medications. We're done using nebulizers. So intubation, other upper airway procedures. I know some of our hospitalists do perform intubation, and so after performing an intubation, you would need to dispose of that N95 and you start using a new one. BiPAP is the other really big thing that I think a majority of hospitalists would utilize normally, and this is something that we are not practicing right now. It again will spray COVID into the air. Again, it's not recommended for patients with possible or confirmed COVID. We are proceeding straight to intubation. Importantly, so obtaining a nasopharyngeal swab to test someone for COVID is not considered an aerosolizing procedure. So you can safely do that with your N95 and continue your extended or reuse of that. So I don't need an N95. You don't when you're seeing a low risk patient, when you're performing a low risk procedure on those patients. You don't need one in the hallways of the hospitals or sitting at the nursing station. You don't need one out in the community. I think it's really important that we set an example for our colleagues in the hospital of other subspecialties, for our nursing staff, for our housekeeping staff that has to go into those rooms just as we do. And to show the importance of this throughout our community, we're asking a lot of them staying home, shutting our economy down. I mean, let's follow these rules and guidelines for N95 appropriate use and PPE appropriate use so that we have enough to take care of the patient, to take care of our patients. We owe it to our teammates. We owe it to our colleagues in the emergency department, in the ICU, and our nursing staff to all work together to make sure that there is enough. So regular masks. So in order to minimize the chance of us contracting COVID, so at our institution, again, we are blessed right now that we have enough to do this. We are utilizing a regular mask in the hospital at all times with all other patient interactions. Again, these also can last the entire day unless you go into a patient's room that has C. diff or something like that. We're also having our COVID patients wear these when we're in the room. If anything, this will only decrease the burden of droplet that's being released into the air while we're in there. So it can only help. So, and finally, it's really important that we are doing all we can to reduce the risk of transmission amongst our teammates and amongst ourselves. From patients that we don't know that have COVID. We really need to minimize our chances of going out on furlough or becoming infected. Our teammates rely on us, and we need to do all we can to be there. So a lot of folks like myself used to use a PAPR for going into airborne precaution rooms. Unfortunately now that's not possible. So those that have facial hair, be prepared to remove it here very shortly if and when COVID comes to your institution. So our system also has created a number of helpful infographics to assist us in really remembering when we want to utilize certain types of PPE. For this one, it's just the masks. And for this, it's the entirety of the PPE. And so we have these posted throughout the hospitals. These are on our intranet. These are on the regular website. And these, again, are customized, though, to the equipment that we have. And so I think it's important for your institutions to have something like this, but also customize and update it according to the equipment that each of your institutions have. We don't want these things being out of date and there being a mistake. All right, here's some other resources. So as I had mentioned a little bit earlier with Nebraska Medicine with the ultraviolet light decontamination. So Nebraska hosts really the major biocontainment unit for the United States. If you recall, I believe they sent some COVID patients there right at the beginning. Additionally, when there were Ebola cases, they got sent there. And so they're really at the forefront of infectious disease management, and their website right there really has a number of great resources to help us. Additionally, the CDC strategies for optimizing the supply of PPE, you'll see that link there at the bottom. Ongoing discussions about N95 respirator conservation, as well as other critical components of PPE. It does have some worst case scenario information, which I am very hopeful that none of us will need to access. All right, so, and I think that's something really on our minds. So it frightens us as well, frightens me. It frightens, if anyone has watched the governor of New York State, who I think has been magnificent in really advocating for not just our system, but all of the patients within New York State and also the country, that we need this equipment. Us as hospitalists, us as physicians, we have to rely on our leaders in the government, I think, and in industry to create and manufacture the resources that we need. Again, I think it's unreasonable to wait for the time that we're going to have unlimited. I think at this point we need to do our part in making sure we have enough of this. We want to avoid things like care rationing, reducing patient visits, with that ethical nightmare I think that comes with that, and that's really beyond our scope today. But this is why I thought this talk was so important, was for me to do my part to help you guys out across the country, do everything we can to prevent this from happening. So in just a moment, I'll open it up with questions. There was just one other little point that I wanted to add that I forgot earlier. So one thing that we have done is, I know a lot of our hospitalist offices are quite small. We sit basically on top of each other, that the quarters are so tight, as especially people start to be able to work from home, from other parts of the hospital. Reach out to your administrations, get additional office space, at least temporarily, for your team, so that your teammates can socially distance, so that one of your teammates doesn't wind up with COVID and causing a number of others to get sick as well. All right, so with that, thank you all so much for your time and your attention, and I would love to open it up to questions.
Great. Thank you, Dr. Case, for that really informative presentation about the strategies that Northwell Health is using to confront, I think, in real time, a little bit ahead of a lot of other communities, the COVID-19 pandemic with their patients. So it's really helpful to hear everything that you're experiencing and how you all are managing it. So as a reminder for folks, if you do want to ask questions, because there's so many attendees today, if you wouldn't mind typing those into the question box, and we will try to moderate and get to as many questions as we possibly can. There are going to be some questions that are, I think, probably going to be difficult to answer. And Dr. Case, feel free to indicate that. I think we all know that this is an ever-evolving situation, and we're all learning in this together. So we'll start off with a couple questions actually about surgical masks. Mm-hmm. The first one is, physicians in their group are advocating to wear surgical masks on site at all times. Do you have any thoughts? Are there evidence-based recommendations for that? Is that something that any of your sites have instituted?
Yeah, so we are wearing regular surgical masks at all times on our sites. I think part of it is that honestly that we have enough of them and that we're able to do that. We do not have solid evidence that shows specifically that for COVID-19 that this will reduce transmission risk. A lot of this is based on our clinical experts in infection control and infectious disease guiding us on this. And what we have seen though with the data that we have in just tracking our folks that have had exposure to someone not wearing an N95 who does have confirmed COVID, if the provider had a mask on and the person with COVID had a mask on, we are not seeing real evidence of transmission of COVID to the healthcare provider. So although we don't have that great true research data that's showing us that, anecdotally it does seem to be working.
Hey Josh, this is Eric. A couple people asked about N95 versus PAPRs, and I wonder if you could elaborate on that. One question was, when do you use a PAPR versus N95? And maybe the preceding question was, what happens if you actually fail your N95 fitting? What do you do?
If you fail your N95, and that's an excellent question. So, that in the past, that would be an easy question. That would be an easy answer, and you go to a PAPR. The issue with PAPR supplies, it's the same issue as N95 supplies, is that these patients are considered both on, this is not your standard airborne tuberculosis precautions patient. This is extremely infectious stuff, both on droplet and contact. And so there's my worries and our worries as a system is that we barely have enough N95 supplies. We really don't have enough PAPR supplies. And I think I don't have a great answer for that one, unfortunately.
Yeah, I don't either. I'm not a PAPR expert or an N95 expert, but what I've seen in my own organization is that they'll try different size N95 masks if they have them. And if you're a man, although I guess you could be a woman too, but if you're a man, make sure you're clean shaven, because it's really the facial hair that often causes what we've seen, I think, is the failure of the N95 fitting.
Yeah, absolutely. And I think that was the point I was trying to hammer home on that other slide where, I know you and I talked about this before before we started, is it really important to be clean shaven, to do all that we can. And I agree, experimenting with different sizes and different mask types, if your facility at this point has them, to try to find something that fits, because there's definitely not going to be enough PAPR supplies to go around.
Thank you. There's actually been a couple questions. I think I'm going to try and consolidate them into one, but it's basically about, is droplet precautions enough for COVID-19? There are a couple comments that their hospitals are recommending just, I think, surgical masks for COVID-19. And is that enough for COVID-19? And I think in the follow-up question is, if the answer is no, is a regular surgical mask okay for PUIs, patients under investigation or suspected COVID-19? I think I know your answer and mine, but it'd be nice to hear what you think about that.
I think that if you follow the CDC guidelines, the answer is that it's not what's recommended. There is gathering information that perhaps it's okay. I think that's a hard discussion to have with your infection control, with your supply folks at your hospital. And I think really actually having the CEO reach out to politicians at the state and trying to tap into whatever resources there are to try to get them. I know that this is hard though, and that may be the best that is able to be provided right now, and that's hard.
Yeah, I agree. I mean, if you have nothing, if there are no N95 and PAPRs are becoming unicorns, I think, in many units,
Yeah.
then you've got to go with what you got to go with. Another question, I'm interested in this as well. Somebody asked, what do you think about, the hairnets and booties? I know that they're not necessarily strongly recommended, but what are your thoughts on those?
Again, I think as I had said earlier, so if the hairnet, especially if it helps you or your teammates to feel more comfortable and helps with the anxiety of going into that patient's room, absolutely go right ahead. I have not read any data, especially on the bouffants, that it causes a problem. So if you guys have got them, and you feel better about it, okay. That's my perspective. That's my perspective on that. I'm not sure what maybe you think on that.
Yeah, I think I'm the same way. I think personally, I don't use the bouffant. I like that term actually, or the footies.
Yeah.
I'm much more about inhaling it or putting it on my fingers and touching it.
Yeah.
But I
I'd
do
rather not touch
think
my face today. That's that's for sure. So I leave the booties alone.
yeah, exactly. It's interesting. A couple of people also ask about DIY. That make your own mask. Do you have any thoughts or comments on those?
Yeah. So from what I've read, and it's I suppose better than nothing. You know, there's not good data, and there's not quality control. What material is used? How they're manufactured. I think for strolling around in the community may not be the worst thing. If that's all you guys have in the hospital to cover your N95, then or to walk around in the hospital, then again, I don't think it will hurt unless you don't wash it, you expose it, it's been dirty for days. So I think if you're going to use them, keeping them absolutely as clean as you can and not accidentally winding up touching your face more because you got it on. That's my perception there. But again, we're kind of with homemade masks and things like that, we're unfortunately in an area we don't have data on.
Yes, I agree. A few people are wondering, and I'm sure they mean this in only the most professional way, but what you do with your clothes when you get home?
So we are doing the scrubs. So I subscribe to the, I haven't been one that has taken them off in the hallway before I get in my apartment, but I certainly have been removing them and washing them quite quickly. And whether there's not good data for that, it helps with my own anxiety though, I think.
Yeah, I think bed bugs freaked me out and made me change in the garage more so than this.
Bed bugs is a bad word here in New York City, so.
Well, Baltimore too.
Yeah.
You talked a little bit about this, but so you're not. There are a couple questions about MDIs versus nebulizers, particularly because MDIs are so short. So one is we recognize that maybe it's not ideal to use nebulizers. And so there are some follow-up questions about, do you use nebulizers if patients are not suspected to be COVID positive or for your non-respiratory patients? So I guess the question is, do you ever use nebulizers given how short the MDIs are?
Yeah, so we are able to use them for people that we're as certain as we can be are not COVID positive. We haven't again had a huge issue with shortage of those at this point, but it's an absolute no on using them for the COVID patients. I think you just got to be as reasonably sure as you can that patient does not have COVID.
Yes, agreed. Josh, have you looked at any other questions? I've been running through the questions as I've talked, but I'm not very good at multitasking. Josh Lapp, sorry. I didn't mean our Dr.
Too many
Joshes.
Joshes.
Yeah, a lot of Joshes. They're all good, though. You can't have too many Joshes.
It's a great name. I like yours, Josh.
Thank you. So there's been a couple of questions around cleaning and storing N95s, and I know you touched on that some institutions are like Nebraska, are looking at UV to sanitize some of their equipment. But I was wondering if you could touch on, you know, if you are doing any sort of strategies for cleaning and that use N95s, and then are you just following the you know, the paper bag storage method?
Yeah, we are. Yeah, so we're following the paper bag storage method. So our strategy for, you know, keeping the N95s clean is covering them with the surgical mask before going into the patient's room. I really was impressed with Nebraska's UV protocol, especially if surgical masks are a little bit short at your institution. I think that that is a excellent strategy. They use as much reasonable evidence basis as they can for the safety and efficacy of it. So it's definitely something worth looking at. And on their website, they have a very step-by-step protocol for doing that. And the UV that they use, I think, is something that the vast majority of hospitals have. It's the same stuff they use for room cleaning, I think. So I think it's something achievable at the vast majority of institutions. Especially if you don't have enough surgical masks.
Another question that is maybe a little bit opinion-based, and I'm not sure if you've faced this with any of your hospitals, but are there tools, resources, even just you know, sentences for folks to advocate for themselves to their health system around you know, using surgical masks in some of these ways to keep N95s clean, to you know, using these resources in ways that maybe haven't been used before?
Yeah, so I think an important part of that, though, is, so, you know, part of that conversation needs to be an understanding of what the supply really looks like at your institution. And I think at a lot of places, you know, the answer I mean, there's a lot of folks that have asked for N95, asked for various stuff at our institution that we've had to tell no to, simply because, you know, we would love to give everyone an N95, but we don't have enough to do that. And if at someone's institution there's not enough surgical masks to do that sort of thing, then that may be why they're saying no. So I think it's important to understand why they're getting no. And on top of that, you know, working with your infection control officer, as well as understanding the supplies, to figure out what is the best possible strategy at your individual institution. And that, I think that's the most important thing, is that, you know, the way that we do it, the way that Nebraska does it, the way that various other institutions do it, you know, there's there's differences in what you have a lot of, what's even more scarce. So I think helping to facilitate that conversation and helping to be a part of the solution is the key to that conversation, as it is with, I think, most conversations with our C-suites. It's hard to go in there and just say, I want it. I think they would have given it to us already if it was that easy to give.
Somebody wants to know how you. There's a question about how you actually eat when you're on duty.
So, not too often, but it's, you know, getting on. So I don't, you know, we don't keep on the N95 all day. So ideally, you're kind of doing a big chunk of rounds with the N95 on, and then take it off, and at some point try to take a little bit of a break and kind of wash your hands a bit maniacally before you do it, but go down and sneak some food and carry on with your day.
And do you eat? We used to eat on the team rooms and on the wards. Is that where you're eating now, or do you go to another floor and quarantine yourself in a closet in the cafeteria? How do you separate
Sometimes
your areas?
sometimes in the cafeteria. I mean, using a lot of the cleaning wipes. I've been bringing a lot of my own lunch, so I don't have to go to the cafeteria. So that's one place I've gotten kind of nervy at this point is the hospital cafeteria. So I've been bringing a lot of my own food from home, and we have worked out, having more space in our institutions where we're not in that cramped team room anymore, and so I am sometimes eating in that can eat in that team room with a little bit more space and plenty of cleaning wipes.
Some of these questions are getting hard. One is, I think I'm going to go with it's relatively easy, but I mean, really, some of these dilemmas I think that we're having to go through as clinicians is tough. But one of them is important question: is there a risk of spreading infection with keeping the same N95 when seeing multiple patients? And there was another question related to whether you have a COVID positive versus a COVID negative, or even a suspected. Do you use the same mask? I think I know my answer, but I'd like to hear yours.
Mm-hmm. So again, with the N95s, we are using the same mask, because there aren't multiple masks to use, but also as one of the pieces of evidence I presented earlier, and that the vast majority of pathogens do remain trapped within the mask and aren't going to come off either on your patient or on yourself. And whatever strategies we can do to help protect that mask, again, help with that. So, for COVID positive or presumed or pending COVID patients, we are using the same N95 mask. And the important thing I emphasized earlier, for patients that are now COVID negative, I'm not wearing an N95. We should not be using that PPE on that patient. And just one other on a side note for that, in our data, it's we've done a follow-up test because we weren't quite sure on a large number of initial COVID negative patients, and of the ones that we have tested, so there was a meaningful clinical suspicion of that patient not, that test being a false negative. It was a couple percent that were false negatives. And so, unless you have really high clinical suspicion, so very classical signs of, COVID, fever, cough, and the pneumonia findings on your chest imaging, and no other plausible explanation, I mean, we're believing that negative COVID, and we're not using PPE for those patients anymore.
Okay, that's helpful. Here's one I don't know the answer to. We do not have enough of the correct size N95 mask. What's better? Wear a small size N95 mask if you're sized for a medium, or wear a surgical mask? If you only have two bad options, which should we be picking? I don't know the answer to that question. I don't know if you have thoughts on that.
I don't know the answer to that either. I think that my best recommendation would be to, try getting fit tested for that mask that's too small. And if that winds up working, then good. I think if it doesn't, we're at the same conundrum earlier as to, is it okay for both people to wear a surgical mask? And there's not a great answer there.
Oh yeah, that's a good answer. I think that's right. Maybe see if you can get fit tested for the smaller mask. That's a good idea. I know, again, our fit testing nurse is a very experienced fitter, and so she can mold, I think, many masks to fit a variety of faces.
Yeah, I think
there's
that's
one question.
Mm-hmm.
Yeah, no, there's just a question. I think that there's been a couple questions about asking about storing of the mask, even though you've gone through it, and I just want to make it clear. You're recommending that for your N95, it should be in a breathable bag, like a paper bag, rather than a plastic bag. You want it to dry out.
Yeah, you want air to circulate, basically. Yeah, and so there are some breathable plastics, and that's fine. Paper bag seems to be the most common choice. Make sure you don't get it wet, caught out in the rain, though, I guess.
That's true. Joshua Lapps, what have we missed in our banter going back and forth so far?
I think you've hit on a lot of the major themes of the questions. You know, one of the things I think that I think has come up, and I'd love to hear your thoughts, Dr. Case or Dr. Howell, is around having these hard conversations with staff members, with other, you know, your peers in your group about the, you know, the realities of the on-the-ground situation in terms of supplies. And I think, you know, there's an enormous volume of information out there that at times feels conflicting. And I believe someone even mentioned, you know, the potentially getting conflicting information, or what feels like conflicting information from the federal administration. How are you managing these difficult conversations about PPE with your frontline providers, and you know, balancing their needs and fears and anxieties with the realities of you know, what the institution has, and what the short-term realities of the on-the-ground experience is going to be like?
Thanks for the easy question. So you know, realistic, it's, you know, I think it's honesty, and empathy, you know, recognizing the anxieties and fears that, you know, really all of us have right now. I'm scared to death of us running out of PPE. I don't know what I'll tell my team. But again, so recognizing people's anxieties, people's fears, I think understanding this is normal. I think you'd be a sociopath if you weren't scared about what's going on right now. This is unprecedented in our lifetimes, and just knowing and recognizing that, and whether it's, you know, through the Society of Hospital Medicine or just with your teammates, just sit with that for a minute and, you know, let it wash over us. So we're going through this. We're going to get through this, and it's okay to feel scared about this, and be honest about the situation that we're in. If we're short on PPE, hey guys, this is why we're doing this. I'm so sorry. I wish it were different, but it's not. This is what we got. Our patients are relying on us. And I think all of it, a crisis like this, I think, is why all of us went to medical school in some form or another in the end. And so I think we're going to work together to get through this, but yeah, there's not an easy way through.
Great, thank you, and sorry for pitching a toughie right at the end.
Oh, these are hard. These are hard conversations. We've had these really hard conversations throughout from the highest levels of our health system, and just, you know, again, and also being just consistent about the message, making sure we're not making, you know, special deals for certain people that get it and certain people, you know, don't. It's about need, and it's about the reason for it.